Hello everyone, we are going to talk about some landmark audits in urology and the impact for the same. So way back in year 1974, Professor Blandy and colleague asked a question to the system wherein it was a conventional norm to undergo intravenous pyelogram before the prostatectomy for patients, whether there is an actual need for doing it. And at the end of an audit, they concluded that it delays the surgery by 3 days without adding any extra benefit clinically because it does not change the decision of prostatectomy and it adds to the cost. That's why they considered factors in not favor of having IVP before the prostatectomy. So that's an importance of an audit. It should give us some directions. It should give us some inputs which would probably change the way the things are managed at that point of time. So I'm going to talk about two important audits in urology in next few slides. Most important is NPCA, National Prostate Cancer Audit. It is in UK. It started from year 2013. So it's been last 7 years. This audit is being done every year under the aegis of Royal College of Surgeons of England, Bowes Oncology, and Public Health England. The aim is to have improvised diagnosis and treatment for prostate cancer, to have quality checks and reassurance info and release information bulletins for healthcare providers and patients. It covers the data from various cancer registries, most important being hospital episode statistics data, and also has inputs from patient experience surveys, EPIC scores, the radiation scores, and the chemotherapy updates. If you actually go onto the website, individual trust-wise data will be widely available, divided into diagnostics, treatments, and support services. For example, if you analyze the data from particular trust, that will give you firstly the data quality and then the outcome measures, and also compare these outcome measures with the national standards. So there are around 14 performance indices which they generally consider every year for evaluation of their parameters for prostate cancer. Just to give an example of annual report of 2020. So there were 23% hike in the diagnosis of prostate cancer. 13% patients were diagnosed in the metastatic setting. Coming to the treatment allocation, 5% over treatment for low risk prostate cancers and 29% under treatment for high risk prostate cancers. For treatment outcomes, nearly 14% patients had readmissions within 90 days of surgery. Almost 2 out of 1 in 10 men required or had GI or GU toxicity within 2 years. Nearly 90% patients had good experience of their prostate cancer management, with 90% being allocated to a dedicated nurse practitioner. So based upon these results, they come with some recommendation, which is also an important pillar for healthcare providers. So in 2020, they encourage people to have more transperineal biopsies. They encourage people to give more options of active surveillance for low risk cancers. It also releases information bulletin, which is important for patients. It gives information to them about everything on prostate cancer, about the audit, etc. Let's come to the important role of these particular audits. Clinical impact or the papers coming out of this audit, nearly 85 publications you can explore if you actually find it out. Some of these papers are very landmark papers. For example, one reported in Lancet Oncology recently on the public reporting outcomes of radiation oncology. They also compared the data between individual doctor entered registered data from the Bowes registry with these hospital episode statistics for quality assurance, and they ensured that the data matches. An important pillar of this audit, luckily I was a part of one of these audits, a transperineal versus transrectal prostate biopsy. So we conducted about 500,000 prostate biopsy data analysis over a period of a decade in UK NHS, and mentioned that transperineal scores over transrectal in terms of having less of infection, sepsis, and hence less upstream and downstream cost for management. And these are the two papers which are going to be cited in AAU guidelines, and that's the reason or the motto of an audit is these two papers are telling us that transperineal is the way forward, unlike transrectal biopsy, which was done conventionally. Second audit which I'm going to talk about is SEER database analysis. It obviously is from US. It started in year 1973. It covers nearly half a population of US, analyzes patient demographics, tumor morphology, stage, course of treatment, and follow-up. Includes the data from various registries, including census, mortality data, and cancer registries. The goals of SEER database are similar to what prostate cancer audit does in UK. It gives us some information on temporal changes. Most importantly, it gives us information on some iatrogenic cancers. So that's the way the temporal uh, representation of a cancer incidence wise and a mortality wise with respect to different male and female sex, which is represented in the diagram. It also gives fact sheets about particular cancer. Just to give an example of prostate cancer, it tells about median age, 7% the patients getting diagnosed in a metastatic setting, and a 5-year overall survival with respect to various stages. Just to sensitize ourselves, probably we do not have any data of similar sort in India, wherein we know that probably more than half a patient which we see of prostate cancer newly diagnosed individual are more than in metastatic settings. So coming to the important implications of this particular audit, so I'm going to restrict it for certain cancers. So bladder cancer, I was talking about iatrogenic cancer. So they analyze a large data set of bladder cancers and mentioned that previous history of radiation for prostate cancer is one of the most important cause of having bladder cancer, which is an important landmark opinion out of this particular paper. Squamous cancers, all of us know that cystectomy is the gold standard, but why and what's the reason for it? Because a large data set of CRB database analysis tells us that the other modalities of treatment are not useful. Some prognostic nomograms calculation for some atypical cancers like upper tracheal cancers can only be possible if you have a large data set. Needless to say, robot versus open, which is a current hot debate in particular field at this point of time, is also reinforced by the SEER analysis. Similar way, some large figures on testicular and penile cancer also tell us that there are certain nomograms which one can calculate for lymph node positivity estimation, which is again a hot debate in current standards of uro-oncology. Current era of artificial intelligence, when you would want to have some machine learning based approaches for nomograms, you need a large data set of patient population. So around 1,70,000 patients for prostate cancer they evaluated for estimation of prostate cancer specific mortality, and their survival quilt model correlated very well with the existing model. So that's the future, and for this you need to have a large data set of patients. Again, comparison of a SEER database analysis with NPCA, the two audits which I mentioned here, I got a nice paper to summarize this. It probably tells us that in US, as compared to England, they are potentially over-treating low-risk cancers, and in UK, they are under-treating high-risk cancers. So that's my concluding slide. Many thanks for USI Collaborative Research Committee opportunity and this particular talk. We are here for having some collaborative data coming out of India, and we are here to have some efforts in that particular direction. Thank you so much.